Thank you. And before we start, we'd like to acknowledge that we operate on the ancestral and unceded territory of the Coast Salish people, including the territory of the Musqueam, the Squamish, and Tsleil-Waututh Nation. We recognize their ongoing contribution to the health and well-being of their community. And I also want to express our respect and gratitude for the opportunity to live, work, and serve on this land because of them. It is crucial that we honor and support the right, culture, and history of Indigenous people as we work towards reconciliation and improving healthcare services for all of us here. So without further ado, today's session, once again, is about BC privacy law updates, the impacts and opportunities for health research and technology. So for those who attended our first session, you should know that we have amazing 5 speakers, but for those who unfortunately missed our previous session last Thursday, I would like to reintroduce them briefly. Due to the time, I won't read all their bios, but if you're interested, you can always go back to check our Eventbrite registration page. You can read all their background and their titles, what they did in the past. So our first speaker is Rasika Rajapakshe. Is a senior medical physicist at the BC Cancer and the lead medical physicist for the BC Cancer Breast and Lung Screening Programs. Our second speaker is Heidi Longstaff, is a PhD level trained ethicist and the new chair of the UBC CNW Research Ethics Board, as well as the director of the Research Integration and Innovation at PHSA. Our third speaker is Sybila Valdivieso, is the executive director and senior legal counsel at our PHSA, where she works with experts in governance, ethics, privacy, analytics, research, healthcare, and technology in support of the healthcare system. After that is Heidi Giesbrecht, who is a Senior Executive Director for Strategy, Innovation, and Portfolio Management with Digital Health Innovation at our PHSA in partnership with BC Ministry of Health. Last but not least, if James is here, James Bayne is a Senior Executive Director, Information Security for PHSA. He's responsible for the delivery of cybersecurity services to regional health organizations in the Lower Mainland and application-specific security services to the Ministry of Health. So let's welcome all our 5 speakers, and I'm going to change to the speaker slides and then let me know if you can see or not. Are you able to see the slides? Thank you. Then Sybila, the floor is all yours.
Yes, thanks. So good afternoon, everyone, and thank you for coming. I think many of you attended the first seminar on July 18th, and so what we wanted was to respond to you. There were many good questions, and some of those questions we identified that they weren't really for those of us who are presenting here and who were presenting on July 18th. They're questions that need to be answered by specific areas of our organization. So I don't know if we have our colleague Michael Koss in the audience. He's the Director of Data Governance at PHSA. He may be here. Maybe he can raise his voice if he is, or say something.
He is here, and we can make him a co-host as well.
Just a quick opportunity to just say hello. And then what we planned on doing is those questions that we identified that really needed data governance response, we will be referring to him. If we can give him a chance to say hello, that would be great.
Okay, Michael, you should be able to unmute yourself now.
Great. Hello, everyone. Yes, thanks, Sybila, for the introduction. Yes, I'm the Director for Data Governance for PHSA. And we are working to implement a number of processes and standard practices around data access, use, collection across the organization. So happy to help with any questions I can that involve the data governance area.
Thank you, Michael. And I'm now going to turn it over to our colleague Heidi Giesbrecht, who, because she is working on the digital health side of things, there is a AI council at PHSA, and there are some questions that were posed that we thought she may have some comments on that where they could be directed. So I will let her speak.
Thank you for that, Sybila, and fantastic questions that we received from last week's seminar. Look forward to continuing the dialogue. I can offer that we do have an email address where I would invite you to reach out to us. That's at digitalhealthinnovation@phsa.ca. We'll add that into the chat as well. And just want to offer that we are looking at ways that we can start to bring forward a center of excellence and communities of practice around the work of implementation and opportunities to align on business and clinical priorities and research priorities in the digital health space as we advance on generative AI and AI type opportunities. So really excited to see that work continue to evolve and engage this community as part of that as well. So please do reach out and we'll look forward to offering back some insights in response to your questions.
Thank you, Heidi. And just before we go to the land acknowledgement, we just wanted to say, I know we put in a disclaimer in our cover page, it's not showing up, but it is important to us because for many of us who are presenting here today, we've been doing some of this work both professionally and within the organization where we work, but some of the comments we may be making could be our own thoughts and ideas on the issues. They're not necessarily the views of the organization we work for, nor are they at PHSA or the Ministry of Health in some circumstances. So we want to make that really clear. And secondly, we're offering legal information. We're not offering legal advice. And so there isn't any kind of solicitor-client relationship being developed through the presentation, and that is just something that we need to state at the outset. Thank you. Our colleague Holly is taking over from here for a bit.
Yes, if we can go back to the slide, the land acknowledgement slide, please. Yeah, we wanted to read something that was a little bit more specific to what we're going to be speaking about here today. I'm going to read it because I think it's well crafted. We wish to acknowledge the Indigenous peoples of all traditional and ancestral lands we work from today. Those of us in Vancouver acknowledge that we are on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. While this seminar occurs in a virtual platform, we ask for a moment to recognize the lands, to remember that there is a rich Indigenous governances that exist, that are ongoing, and that will go on into the future. It is particularly important to recognize this when we gather to discuss legal structures, for the law has traditionally oppressed Indigenous communities. Also, when we discuss legal aspects of privacy and security, we want to be thoughtful about our dialogue about Indigenous concepts of privacy and collective privacy, as well as data sovereignty. We want to make strong efforts to honor the historical and current contributions of Indigenous peoples as part of engaging in a meaningful reconciliation. Thank you.
So based on that, I think we're now moving to the update that we're going to give on privacy laws in British Columbia. We are concentrated primarily, if you go to the next slide, on, I think we all know what FIPPA is. We've all worked with FIPPA. This is the Freedom of Information and Protection of Privacy Act, which is really the primary public sector privacy law in BC. For many of you who work with privacy issues, you will know that it was substantially updated in November 2021, and then some of those updates didn't come into force until February of last year of 2023. And so we've just outlined here some of the key things. The data residency was a long-standing challenge for those of us working in public sector. The requirement for public bodies like PHSA and many other public bodies to keep personal information in Canada was removed. And I've noted there that it was for that use of software tools and services. And this was happening at the height of COVID, of course. But the requirements now to carry out privacy compliance reviews increased. So we now have privacy impact assessments that have to be carried out with every initiative. And where there's sensitive information, which FIPA doesn't define, then there needs to be a further risk assessment of how any sensitive information is going to be stored outside of the country. That relies largely on security requirements, of course, to make sure that that information is, first of all, that there's a good purpose as to why it needs to go there. In cases, for example, of vendors where we really can't find similar product or similar services in Canada, those kinds of things. But again, the big thing is ensuring that all of those security pieces are in place so that that information is protected. And there have been a lot of discussions about the fact that there isn't a definition of sensitive information, but health information is by its nature considered sensitive and has been designated that way by the Privacy Commissioner. So just moving to the next slide there. The other big update to FIPA was the establishment of a privacy management program, which sets out many different accountability requirements for public bodies like us. I've listed some of them here, which is really to have an individual at each public body that's responsible for being a key point of contact of all privacy matters, supporting and developing policies, ensuring compliance with the Act, and then developing process, which we think is actually positive. I mean, many public bodies and certainly at PHSA, we've had process, but now it's actually mandated and we need to be really clear. So the ways that it's helpful to research is we are working quite closely with Holly to develop procedures that address privacy and research, because we've had a bit of a scattered process where people don't always know where to go for what, and we're working quite hard on that. In most cases with research, there isn't the need to do a privacy impact assessment because the nature of what research is, if it's going through an REB, is not an initiative of the public body, and so it doesn't fall within that ambit. But there are other components that touch on the public body on the institutional side, and those are the things we're trying to address. Again, you will see there requirements to ensure service providers are aware of their obligations. You can move on to the next slide. And then the big thing is mandatory breach reporting. So this was an outstanding issue that had been kind of what I would say had been in the books for many years. I think there had been an ask from advocates in the public sector to ensure that there was an accountability. So we are now required to notify the Privacy Commissioner of any privacy breach that could, I've put in as much as I could in here. I know it's not a lot, but could reasonably result in a real risk of significant harm to an individual. And we have to do that without unreasonable delay. And also notify the person whose personal information has been accessed or disclosed or stolen, etc. And then there are a lot of different requirements under the regulations as to how this has to be done. So it's very specific, and new fines for not complying. Move on to the next slide. Thank you. I wanted to also talk very briefly about updates. We spoke a little bit about the Artificial Intelligence and Data Act at the last session, and FIPA, of course, is public sector, but we have two pieces of legislation that cover the private sector in BC. The Personal Information Protection Act is really, or what we call PIPA for short, and most of you, if you've worked with issues in privacy and private sector, primary care is a good example, you will have come across PIPA. Sometimes if you work with our health sector partners, for example, at Providence is an institution that has a hybrid application of the law. So they have areas of their institution that are subject to FIPA and other areas that are subject to PIPA. And so there have been, I would say, updates in that there have been different kinds of decisions being made. But the big issue for PIPA is that there's, because we've got a privacy management program now in the public sector, there is every indication that more requirements are also coming to the private sector. It's just that it's a different way to account for those requirements, a different kind of accountability. And a lot of what happens under that piece of legislation is based on consent. So it operates differently. The second piece that I've put in there, Personal Information Protection Electronic Documents Act, this is private sector legislation that applies at the federal level. So it applies across Canada for specific federal created organizations. And so it has an application, a limited application in British Columbia. So this is why I've added it here. It is going through amendments through that Bill C-27 that we discussed at the last session, which is the Digital Charter Implementation Act. I apologize in advance, this is so wordy, but I've been trying to reduce it as much as I can. That Digital Charter Implementation Act is trying to create 3 pieces of law. The Consumer Privacy Protection Act that's listed there, which will completely replace PIPEDA, and then 2 other pieces, one called the Personal Information and Data Protection Tribunal Act, and of course, what we call for short AIDA, or Artificial Intelligence and Data Act, which we spoke briefly about. And what these do is the Consumer Privacy Protection Act is really an update to the privacy law at the federal level and a true alignment with the European laws for privacy, which are generally considered to be, depending on who you talk to, the most advanced or the most restrictive. So there are various interpretations to that. But what it will do is it will implement a whole bunch of new individual privacy rights, which align very closely with European law. For example, in some ways, the right to data portability. And we have to keep in mind in thinking here that we're talking about private sector actors, not public sector. So here we're talking about basically commerce, industry. And so this would give individuals the right to say, I want to know where my data is held, and I want you to take my data and move it to another organization. There are a lot of different rules about how that would happen, but that's what it would bring forth. It would bring also the right to delete data, individual right to delete data, and a number of other aspects that would be implemented. The key part that I think is very important is that it would provide the Privacy Commissioner at the federal level with a true regulator authority, which currently the Federal Privacy Commissioner doesn't have. So the authority to review, to audit the activities of private sector actors, and also to issue orders and to make recommendations for financial penalties when private sector actors engage in wrongdoing, which is basically violation of privacy. That would be the wrongdoing. The second piece of legislation listed there is the creation of a tribunal. And that tribunal would basically be where an issue would be referred by the Privacy Commissioner for further consideration, almost in a court-like setting to evaluate this. And the penalties that are being contemplated for the wrongdoing are very high. I think the piece to keep in mind here is that this is kind of the alignment of what's happening as we move into a digital space. So the law is trying to say, we are doing all of this, we're moving everything into digital, but we need to find ways to manage that. We need to find ways to account for that. And how do we make all of these private sector actors accountable? And so some of the rules will seem very heavy at the beginning. And there have been, and I think I got into that a little bit in our previous discussion, there's been a lot of discussion and a lot of controversy about these 3 pieces of legislation. The third piece is what we call AIDA for short, and Artificial Intelligence Act. And really what it sets out to do is to regulate the use of AI systems. It's defined what AI systems are. is defined very broadly, but it also sets out this very heavy accountability on private sector actors to say, this is why we're using the AI system, this is how we're using it. If we make a decision, this is the kind of decision we're making. There are also algorithmic requirements to provide information about algorithms, and lots of, you can imagine if you're working with technology that would be somewhat controversial, because what kind of information will that be? It could be information that could be a trade secret, and therefore a private sector actor will say, I don't want to do that. So there's a lot of different components here that are very interesting, and we can certainly share what I had thought of doing is an hour isn't enough to have this discussion, so we can send a reference to our colleagues, to Sally and Beth and Jonah, that we can list some references on some of the materials that we have looked at for these presentations. The other area that I wanted to mention very briefly is there are a number of self-governing Indigenous groups in British Columbia who have implemented their own FIPA of sorts. It's a Freedom of Information Protection and Privacy Act that applies exclusively within the jurisdictions of their government, and it's being used primarily for government information. So I think that's quite interesting and a reflection of our move forward to reconciliation and alignment in that way with the laws. There are two other pieces of legislation that I've listed here. The Anti-Racism in Data Act, which came into force in 2022. It's a piece of legislation whereby the province created an opportunity to be able to collect demographic data, and that involves, the idea behind it is really to be able to collect this data to research what kinds of issues are going on, and to look into racism in different institutions, primarily in government. So it doesn't apply to all public bodies, and so, but it's an important piece of legislation to look into, especially if you're doing research in these areas. The last piece there, the Intimate Images Protection Act, that came into force in 2023. It is a piece of legislation that attempts to address the challenges of people sharing a lot of intimate images online, sometimes sharing those images about others without their consent, most often without their consent, and the problems that have arisen. A lot of these problems are among minors, but not just minors. It's also happening among adults, often in intimate relationships, hence the name of the act. And it's a very big problem with young people because they're operating entirely in the digital space. And so again, it's the law trying to say, let's put some safeguards here. The regulation to that act, I think, is very interesting because it provides the opportunity for a minor in British Columbia. And in British Columbia, anyone under 19 is considered a minor, but a minor that is between, I think, older than 14 and obviously younger than 19 can bring action on their own behalf. They do not have to have anyone else acting for them, to the Civil Resolution Tribunal, which is an entirely online tribunal and a unique kind of, I think it's a pretty unique kind of legal development in BC. And they can do that. They can seek an order and they can make their case online through the entire process, which is quite interesting and a positive part of the digital space. And they also, a minor that is, I think, younger than, no, I'm sorry, I'm trying to think of the ages. I think a minor who is older than 12 but under 14 can also do this, provided they have somebody to represent them. So it could be a parent or a support advocate. And I think we can move on to the next slide. I wanted to say briefly here that the impact of legal updates on health research, the updates that I've listed here For FIPA, there haven't been really updates that speak directly to health research, because the research component of FIPA, the number of the provision has changed, but the statements have remained the same. So there isn't a direct impact in that way. There isn't probably an impact in process, and that is what I alluded to that we are trying to address. And I think Holly will also speak to it a little bit later. But I think now Rasika would like to speak to the next item.
Sorry, I was
You
muted
mute
there.
your,
Thank you so much for everybody. Thank you, Sybila, for all this presentation you did now, and also for the audience that joined in today and those who joined last time. So now that we heard about some of those legal sort of requirements and guidance, as clinical researchers, how do we go about getting involved in the AI? So there are two aspects that I'm going to talk about today. The first part is actually how do we go about creating our own AI systems? And that might be something in the mind of many clinicians, I think. You know, I believe most of the attendees are probably coming from clinical background, just like myself. So because you're coming from clinical background, one of the first questions you need to ask yourself or think about it is that, do I have access to the AI and machine learning expertise and computing resources? Particularly the expertise part is the one. And when it comes to computing resources, assuming that you do have affiliation with UBC, of course, UBC has a cloud computing facilities available that you could use for that. But it's important that sometimes when you get somebody to work on developing or training a model, the model sometimes doesn't train well. And so in that case, you really need some expertise, access to expertise, so that actually you can get the people who are working for you actually can move forward. So that's one of the first things you need to think about that. And then the next thing would be, of course, clearly identify the clinical problem to be solved, right? Now that's where all the clinical people are very good at. And that's where I strongly believe that clinical staff has to be upfront of any AI, either development or implementation. And then more importantly, we have to establish what are the outcomes we are going to evaluate in this model that we're going to develop, right? And then once we do that, we can move forward to selecting what kind of a AI model that we want to evaluate for that. And then once you have that idea, then we can think about how much data would we need to train and evaluate this model. Once you kind of get that sorted out, then you can go through the research ethics approval and data access approval, and assuming that you get all that done. And the next part comes in the extraction and curate the data as appropriate, which include what I believe has to be the de-identification of data. And as far as my experience goes, I would say 90% of your work will be on this. And in general, if you are getting the data from one small system, it's only one system, then your problems are not that difficult. But if you started to get data from multiple systems, your problems started to become exponentially difficult. And some of the work we are doing, we are getting data from multiple systems across the province, and then it makes very, very difficult to curate the data. And you know that those who are interested in AI development, you know that we have to have this thing called the data leakage from train to test. Because if you have a one patient data that you're using for training your model, you cannot have any of that patient data when you do testing that algorithm, right? So you want to make sure that data is very well curated. So that's where you would be spending most of the time. And then my recommendation is that actually capitalize on the AWS, the PHSA landing zone of the AWS, and that will cover a lot of your privacy issues. Because the organization has gone through some of this for enabling this platform to be used for research, and therefore think very seriously about using this way, and that way the data residency requirement is maintained, and it is maintained by our PHSA IMIT. At least they're looking after that for us. So that way, as a clinicians, we don't need to worry too much about some of those technical details and security details. And next slide, please. And then what you need to think about is that, yes, you develop a model and then test it with your own data. You need to verify that it can be generalizable to the other populations. And you need to think about whether, how do we do that? And one option is, of course, collaborate with other institutions, your colleagues, and work with them to use their data to validate. In that case, you don't need to worry too much about the data privacy, because you could send your data to them. Sorry, you could send your algorithm to them, and they can run your algorithm on their systems and then give you the results back. So that way you avoid some of the data sharing issues. And then you can, of course, do a collaboratively published results, right? And then another option is to look at, are there any public domain data set that you could use? Because the public domain data set, they may not be very good for training models because there are some biases in there, but at least you can run it and see whether your model performs well for these things. And one very important thing you need to think about if you are developing your own AI system, can my model provide an uncertainty in the prediction? Like if you look at any of the AI models, they actually don't give you uncertainty. Every AI model actually has a built-in uncertainty. And if you are really going to develop your model, you can actually give uncertainty. This is different than if you go to evaluate a model, if you generate ROC curve, for example, and then of course you can generate ROC curve and 95% confidence interval. That's different. That's the evaluation part of it. Once you have the model developed and then you tested, it looks working well, you did the external validation, and then you're going to use it for clinical predictions. And that prediction does have an error or uncertainty. And you need to think about how you can actually estimate that and then provide it to the user. And it will be almost like a turning on and off. You give the results and then the user can actually turn on the uncertainty in that prediction. So it's very important to think about this. And there is an international standard coming up in the future. You may know the ISO, which is the International Standard Organization, that is comprised of all the national standard organizations. In Canada, we have the Standard Council of Canada, and they have Artificial Intelligence Committee who contribute to this. And now they are working on a guidance requirement for uncertainty quantification in AI systems. So it is important to keep this in mind, and this will, of course, will be seriously applicable to the industry, because they are expected to meet the ISO standards if they have to sell it to different countries. But if you are thinking about developing, this is a really important thing to keep in mind, and then and build this upfront. So next slide, please. And here are some very useful references if you are really keen on doing that. And my expertise in medical imaging, and some of you probably are working with medical imaging as well. And medical imaging is one of the forefront areas of AI development. And they have developed very, very useful guidance. And then I provided them in here. Next slide, please. Okay, so now let's say you develop your own algorithm, and then you decided, well, we don't have the expertise to do that. There's a product out in the market, and we want to use it. Now that's a totally different game. It's a very difficult problem than actually developing an AI algorithm. So again, there is very nice review article that was published recently at the BCCHR Artificial Intelligence journal in the inaugural issue, and I highly recommend, if those who are interested in implementing, go and read this one. Again, they also capitalize a lot of their guidance, particularly coming from breast imaging. And because breast imaging, those of you who may be familiar with it, you know that there is a stringent requirement throughout the whole breast imaging chain, and they actually look into the way they are done. And so, yeah, next slide, please. So one of the things I want to highlight here is particularly this picture on the right-hand side. The left-hand side, is AI development. It's a developer. We talked about it earlier, but now you are going to implement this. In this case, the best way for you to really implement, you have to do acceptance testing. How do you do the acceptance testing? You need to take that AI model and apply it to your own data and see how it works. And otherwise, how do you know that this model is going to work for you, right? And in BC, we have a very diverse ethnic distributions, and the model may be trained in one specific ethnicity, right? And it's very, very difficult for you to actually ask the manufacturer to give you the ethnic distribution of the data that they used for training the model. And perhaps they don't even know that, right? So, for commercial enterprises to access the good clinical data is difficult, so we understand that. But then again, that's okay. But you need to verify that this model is going to work for your population. So this is where I wanted to highlight the the value of clinicians here. And they are the one who understand the data. They are the ones who understand the nuances of the data. They are the ones who understand the nuances of the patient's population. So that's where I think the clinicians have the best ability to contribute to the implementation of AI, is actually helping the organization to gather the data and curate the data and use it for the acceptance testing. I think it's the clinicians has to be upfront in this one. That's sort of my again, as Sybila mentioned earlier, these are not the BC Cancer Agency policy. These are, I'm talking about as a PI working on AI systems over the years, and based on my professional experience, this is what I believe. And then particularly in the bottom, there is a statement in there saying that you have to kind of work with the manufacturer, but I don't believe in that. You don't, because they might, all they want to do is to make sure that their model is going to work for you. Don't talk to them. Ask them to give their model and run it on your data by yourself. Because that way because they may want to make sure that the model works. But what you want to know is actually if the model is really working, right? And that's where the clinicians have the best contribution with the application of the AI. And I think that's all I have to have discussions. And then if there are any questions related to these things, we can discuss that later. Thank you so much.
Thank you. I think it's over to me now. I squished 5 things into this slide, but because I wanted to make sure that I got a chance to say what I wanted to say to this group. I was trying to think if I was going to think of 5 things I wanted to say to this group, these would be them. The first one is that in order to achieve just outcomes, we really need to be thinking about both procedural ethics and substantive ethics. So we're talking a lot about procedural ethics last week, and at the beginning here, we all have legal frameworks of permissibility and regulatory frameworks of permissibility that we have to work within, and that's what we're talking about here. But the substantive ethics of your work, that's what you know. You are the experts in the substantive ethics of your work, and we need to pay attention to both of these things. And I believe that there is a lot more flexibility within these frameworks of permissibility than we sometimes take advantage of. I personally like the way that risk of harm is described in the Tri-Council policy statement. It's just a policy, but I like the way it's described there. It's a proportionate approach to evaluating risk of harm. It looks at the seriousness of harm and the probability that it will occur. So the example I always give is if you have all these data about me and you re-identified and you find out I took a whole bunch of ethics courses as part of my PhD, like who cares? There's no risk of harm to me there. But if you re-identified a bunch of data and find out that I have an STD or something like that, that's a different issue. And that's where we really depend on our colleagues like that do security all around our environments and our programs and at the health authority to take the probability down for us. So there's a lot of really important research going on at the PHSA that could produce a lot of harm if data were re-identified or things like that. But they're scientifically important and we've evaluated, they're ethical. And the way we deal with them, the proportionate approach to risk, is by taking the probability that some of these negative things will occur down by making sure people are working in safe systems, for example. Now, the other thing I wanted to say is that privacy is not an absolute value. So there's a very big difference between privacy law, which is what Sybila is talking about, and privacy as a value, as a bioethics notion that we take into consideration when we make all things considered judgments in ethics. That's what research ethics boards do. They're multidisciplinary discussions to try to arrive at just solutions. And privacy is one of the things that we take into consideration, but it doesn't prevail every time. There's times where it's perfectly appropriate to trade it off to achieve other outcomes. The fourth thing is that inaction is not value neutral. And that goes for all of our work. Everybody on the panel, everybody listening, inaction is not value neutral. There's no avoiding harm. I think sometimes we think, if I do nothing, nothing bad's going to happen. Look, if you do this, good or bad things can happen. That good or bad things can happen. If you do nothing, bad things can happen. If we withhold data for research, there's lots of unintended negative consequences that can happen, harms that can happen to individuals, groups, and whole systems. But there's also harms that can happen when, as the research community leaves whole health authorities out of a provincial study, or at a national level, we leave whole provinces out. There's a lot of unintended consequences there. The last thing I want to mention is something that came up last week about consent. Remember that when Sybila is talking about the FIPA and the privacy law, and I'm sure she'll talk more about this, she's talking about program level, health authority level, and when do we need to notify things, patients about things, and at what point is consent appropriate and stuff. We're not talking about individual research projects. So it's always mystifying to me why people think that like a law or a policy like Tri-Council policy statement would be written in a way to crush research. Why? Why do we interpret it that way? I don't believe that the FIPA, I think the FIPA is great when it applies to research, and nothing changed with the FIPA the last time, as Sybila mentioned. It has a lot of flexibility. It really dovetails beautifully with the Tri-Council policy statement. And this idea that we would require a privacy impact assessment on every little thing you're doing, why would anyone write a law like that? It doesn't make sense. It doesn't add value. And why would why would we require consent for every single data use? Getting back to this idea of unintended consequences, there are huge negative consequences that can come from requiring consent for every single individual research project. So take, for example, if your scientific questions want you to look at a whole population, and you go with consent for that data, then you're going to get a very thin slice of the population who will all look like me, everybody who already trusts the system and already benefits from the system, and everybody else is left out as a therapeutic orphan. So research ethics boards are really good at navigating when consent should be required and when it ought to be waived. It's always been problematized in the Tri-Council policy statement, because something that we have to always have at the front of our thinking is that every time we don't talk and tell a patient about a research study, a consent-based research study that might be right for them or of interest to them, every time we don't tell them that, every time we leave somebody's data out of a study that has a waiver of consent, we are actively creating a therapeutic orphan in the future. It's not a passive thing. We are actively doing that every time we leave somebody out of it. So I want our researchers to think more about what is required to do my science well. Should I be going with a consent-based study, or is a waiver of consent the right thing to do? It is perfectly acceptable for research ethics boards. It's perfectly acceptable under the privacy law. So I'd like to get us right down to basics like that when we're thinking about consent for particular research studies. We do not want to do more harm than good by requiring consent for every single project that we do. That's me.
Great. Thank you, Holly and Rasika. So I want to talk a little bit, but before I go into this, which is very short, because I had been trying to think of what could we say about research in this area, and our colleague James Bayne is here too, so I can ask him if he has ideas as well. I've put in, if we just go to the next slide, some privacy preserving techniques that I know are some of the kinds of techniques that are being considered in computational studies or AI and machine learning around ways to preserve privacy in the context of the digital space, because so much is happening in deep learning and machine learning. So these are just a few, and it's a lot, and I'm certainly not going to read everyone to you, but I wanted to sort of put that image there, and we will be adding some references on what we were thinking about and putting this forward. It is an important concept to be looking into research in the health space around privacy and security. And I'm going to go back to what Holly was saying around consent, because that's very much on point. No, sorry, I do want this image. It was just thinking about what she was saying about consent in the context of where we are and what we've talked about. Sometimes it's going to sound a little strange, but sometimes I like to think about what kind of animal are we, because it's really important and it really defines what our obligations are. So when I'm talking, like Holly mentioned, when I've been talking about privacy, especially FIPA, when we're referring to that, you will see if you look at FIPA, everywhere it says the public body must, the public body may, the public body. So it's really the institutional obligations. And those obligations are with us because we're in public sector and we have very strict accountabilities to the public, obviously. And if we're working in healthcare, we also have those accountabilities to patients because of that relationship in healthcare between a healthcare provider and the patient. It's a relationship of trust. However, the consent piece is a very interesting one and a very important conversation because in public sector, if you look at FIPA, it is not a piece of legislation that is based on consent. There are components of it that require consent at certain points in time, but by and large, it isn't. And that is in big part because privacy law falls under the larger rubric of administrative law. And administrative law is part of a quasi-constitutional level of law in Canada, which is really government law. So it's really about our interaction with government. And although PHSA isn't direct government, we certainly have that perspective. We are funded by government and we carry out a mandate of government. And so many of the services and the programs that we provide have an element where if we were to seek consent, we couldn't do anything and we couldn't get anywhere. And so it doesn't make sense. Now, an individual can certainly take issue with that. And some people do all the time. I happen to sit in an office where I hear about that a lot. And so my perspective is perhaps a little different because in general, I feel that it's really important to allow a person to voice their disagreement. I deal with disagreement all day long, so I'm quite used to it. And I think it's actually really important that we think about what these laws say and why they say what they say, because they reflect what we have agreed to, right? We are the ones that vote for the governments that we have, and then governments develop law in accordance to what the public has asked of them. In an ideal world, that's always how it works. We are lucky enough that we live in a democratic society where that, by and large, is the structure in place. But there are many people in the world who do not have that at all. And so many of the rights in the privacy context tend to be individual, at least in Canada, that's how they've been developed. But we also have other ways of thinking. For example, one is the Indigenous law perspectives around collective rights or collective perspectives of privacy. And certainly even in healthcare, we have collective perspectives of privacy. Public health is an important area where the collective tends to take precedent over the individual rights. And that can be a very challenging issue for many people. There are many people who disagree with that approach. For example, under the Public Health Act, there's ability for somebody who has a communicable disease and they're not following the medical order that's been issued to them. There's the ability for government, or there's ability under the law for us to go to court and seek an order and bring that person to treatment. And that's because that person might be engaging in activities that harm a large population or do other things. And so there are different kinds of powers. And we are at a point in time in our society where we're looking at all of this much more closely. And we have that opportunity to engage in dialogue and think about that. So in the context of this presentation, we're really engaging in the dialogue about what about that privacy interest of that individual? What happens to that individual? But we need to consider those larger pictures around consent and whether or not it makes sense, because it would be next to impossible. And in many ways, we're looking at ways to solving that through the identification of data and different kinds of things. And so these are some of these, they're very computational because they come from a model looking at AI issues. So I think we can move on to the next slide. We wanted to move forward and answer some of the questions that came up in the first part. So maybe we can go there.
Well, the first question is mine. How do we balance the need for large data sets required for AI development with limited data access? And look, here's what I think about this. And I'm always willing to have my mind changed, but I just do not see a way around this. We need a safe environment for safe people in a safe environment doing hypothesis-driven research. I don't see this in a project by project review kind of thing. I don't see this as everybody creating an agreement. I think we need to put safe people in a safe place. I think research ethics boards are fully equipped to review and approve hypothesis generating research. We do it all the time in qualitative research. It's already contemplated in the Tri-Council policy statement. We need to come up with some, now that this is what people are doing, we need to come up with some parameters that make us accountable to the patients who own these data and biospecimens. We are fully equipped to do that. And we're in the process of doing that at our REB, trying to think about this differently. But to me, that's where we have to go. And so it's just kind of a short answer, but I think that that's what we're trying to do in some of these efforts around the PHSA.
Right. I think the next one is my question. Instances of AI developers or doctors being penalized for adversarial effects. So I have not seen this yet in a very big way. I know that there are contractual mechanisms to bring individual developers or doctors legally to make them liable. But the issue around who developed the AI continues to be a challenge because we're looking at non-human decision making. And so that is something that courts are grappling with, but we're seeing a few developments, especially in the US and certainly in Europe. They've adopted an EU AI Act that sets very strict parameters. I don't know where we will go here yet, so it's still very much a developing stage. Sending it to Rasika.
Yes, so the question here is that, if you're going to build a large language model, my first question is, why do you need to use large language model? And that's where you need to think very carefully. And in healthcare, we don't have a general purpose solutions. In healthcare, we have a specific solution for specific problems, right? So these large language models are built to do all things at the same time. And I'm going to use a very extreme example here to sort of highlight my point of view in that, is that, these large companies like OpenAI has built ChatGPT. I would take that as a massive cruise ship they built, right? It got everything you want, and restaurants, even live animal in there whenever they want to slaughter to feed the people, right? You just can travel around the world for months at a time without worrying about landing anywhere, right? So, however, let's just say you are in the lower mainland, you just want to cross the Fraser River. If you just want to cross the Fraser River, would you ever think about using a cruise ship to cross the Fraser River? You wouldn't, right? And this is where the clinicians' information come in. And then, as a person who know about the Fraser River, that river is not, toward the Richmond area, it's not very fast moving, So the lay of the land. That's where the clinicians come in. They know the lay of the land, right? So you can choose what is your problem that you want to solve, and then choose the solution. And there are some small language models that are available, and sometimes there are multiple ways to train them. And again, training a large language model is literally, if you think about one of the things like ChatGPT, it's literally outside of the sort of financial ability of a healthcare organization. And again, maybe the LLM is used in different contexts, but one of the things you could think about is that using what is called small language models, and then you can actually, there's a system called distilling the information from a large language model into the small model, and then train it on your own data. And there are more and more publications coming up and saying that especially for NLP, smaller models are better and they are less likely to do hallucinations. And hallucination is really, I believe you all know what hallucination means when it comes to generative AI, and it's really bad in healthcare, right? We do not want to hallucination about a treatment option for a patient, right? So that's why I would highly recommend think about using a small language model in the area of healthcare. Thank you.
Thanks.
Yeah, I'll take the next question. So the use of Gen AI tools like ChatGPT have become more inevitable. There's always a risk that we might upload data into these cloud platforms, and what are some of the security mechanisms that we have in place to track these? So there's certainly a concern with free services or other vendor services in uploading proprietary information, and we certainly don't want to inhibit the use of access to many of these tools, but we do have the ability to have ChatGPT within the Azure OpenAI environment, which exists within our controlled tenant. So all of that data, the prompts, the outputs, all stay within our organization. I can't get into the specifics of exactly what security mechanisms we have in place or will look to deploy. But it's about classifying the data, tagging, being able to apply policy rules to that. It's a bit of a balance, I think, between allowing the freedom to explore and use all these different tools and keeping our data safe at the same time. So it'll be a little bit of policy guideline focused, and then looking at the technology controls that we can apply to filter out, maybe prompt saying, hey, do you realize that the data you're about to submit to this tool contains proprietary information or health information? And then you can make that decision. Yes, that's okay, or no, that's I want to back out and I might not want to do that. So there's a lot of different ideas coming out of industry at the moment, and we're currently evaluating much of that.
The next question is mine. I did talk about this already with consent, but it's worth repeating. We should be science driven. And I just want the researchers and everybody that's on this call to hear this. Science driven, science driven. Good science is what is going to serve your patients. So if you need to look at a whole population, you should be asking the RAB for a waiver of consent. That will address this potential of bias. And then, of course, we have to make sure that the data are actually available to you. So I already did talk about it, but I'm repeating it just because it's so important.
Hi. So I just noticed that there in the chat, there are a number of questions around privacy practices of the privacy office, this sort of thing. I think those questions need to be directed to the privacy office. Like, we're doing a presentation on sort of an overarching topic. This is conceptual topics. We're not speaking here about the mechanics necessarily. So responding to the question here, how can we be more proactive with legislation, best practices, security and privacy in the context of new technologies? So proactive in what way? So I think that would be part of the question I would have. The legislation is, the law is set out and we are bound by the law. So in terms of wanting to be proactive, I think when we're thinking about that, it's important to think about, where do we go? So generally government is where we go to address a change to the law, an update to the law. Now, currently there is a lot of work being done by our colleagues at the Ministry of Health. And I do think that it isn't a secret that there is work and that there is a strong interest in developing health-specific legislation. And that will be wonderful when it does come and we can address something that speaks directly to our sector. But in any situation with proactive with legislation, that is not something that's within our control directly as an institution. Best practices, security and privacy in the context of new technologies. That is what we're trying to build now as a result of these new requirements. We're trying to build procedures that make sense and that also make it a little bit easier. Make it easier for the people using, but also make it easier for those of us working in this field. We are often not very well funded. So just remember that whenever you're dealing with the privacy office, that we're often the last areas that get any funding whatsoever. So if you work in a program area and you're looking at developing new tools, new systems, please ask for funding for privacy and compliance mechanisms so that we can add another colleague to help support the work. That is just as important for you to do as it is important for us to do. Precedent plays a role in what we do because a lot of really good work has been done already. So one of a key piece of work that has happened here in BC is we've had what we call the GISA, the General Health Information Sharing Agreement, which took a number of years to do by our colleagues. It was spearheaded by our colleague Stephen Tam at Vancouver Coastal Health. Formerly, he was with that institution. And I used to work at that institution at one point as well. And so that was spearheaded and brought all of the health authorities together with the ministry to create a mechanism to be able to share health information. But it's clearly not enough now, right? We're moving and we're trying to update that agreement to address the needs that we have today. So there is a lot of work going on all the time, and there's always the opportunity for you to reach out to us and have a conversation. That's usually the best way that we can engage. I think we go to the next slide if we can.
Yeah, this question number 7, I think I did address this during my slides as well. And if you have only one system that you're getting your data curation is pretty straightforward and it's not so bad. More and more systems you try to combine the data from, your life become extremely difficult because it depends on what you want to do. If you're a company, you want to develop a product, that's a different story. But as a clinician, you want to do your best for your patient, right? So you want to have a very good data set. And that's a very tough situation, right? Some situations you need to have data from multiple systems. They are not connected properly, and then the data linkage is very difficult. But I don't have a direct answer for that, but if you can get the data from one system, that makes life easier for you. Thank you.
We are over time, but if you guys want to finish, we can at least post the responses to the last 2 questions with the video online for those who are going to miss it, as they are really great questions.
Great. So maybe I'll start on that number 8. I think our colleague Michael Koss may have left. I don't think he's here anymore, but a big piece has been the data access request improvements that have been made at PHSA to make things simpler for those seeking access to data. And we are continually developing that across the health authorities and the health organizations. And also, like I was mentioning, updates to the GISA are going on to make that process simpler. Panda has been created. Holly spoke to Panda being a really important component, especially for research. And the HDP platform, of course, that the ministry has instigated, which is great, and an opportunity for researchers to get data. So those are the things I can think of. There may be more.
Maybe I can speak briefly to number 9 and really building on what I said at the opening around wanting to work collaboratively across the sector with partners that are clinicians in program planning, research, so that we can really involve those voices and perspectives as we plan and look at where there's opportunities for us to introduce new ways to use AI in our clinical settings and business settings. And so again, that's where we really need to partner in this space. And we're working hard to establish those structures and tables so that conversation and dialogue can continue. And I would very much invite you to reach out to our digital health innovation at phsa.ca. There's a fantastic team behind that inbox that would love to have those conversations with you and pick up the thread of where these 2 seminars went over the last couple of weeks. And there's a journey that we need to take together in this work. And we really see that there's an imperative for us to look at how we can leverage AI to leapfrog the transformation priorities in BC and in our healthcare system today. So very excited about where we're going. And again, just echoing the value of that partnership across perspectives and with yourselves on this call that are motivated in this space too.
Thank you so much, Heidi. Oh,
I
yeah,
just want
go
to add
ahead.
something for that one, and then particularly, as clinicians, you are the one who really understand your patients and their data. And that's where you can contribute the most. So I just want to leave with that. And you know that as a clinician, you understand the nuances. I did mention earlier, I can't, highlight the value of that. And yeah, you can have many machine learning engineers, whatever, they don't have the domain knowledge. It is you, the clinicians, who have the domain knowledge. It is very important to use the domain knowledge in the creation, testing, and application of AI. Thank you.
Thank you so much, Rasika. I know it's like 1:07 and many of you have to go. So I just want to make sure, if you missed some of the other previous session, they will all be available on our Learning House, slides, which you can see here. But so you can always scan the code here to rewatch what you have missed or our previous session. The next one is about the optimizing maternal and newborn health in the digital age. So it's on September 26th, Thursday at 12 p.m. So if you're interested, you can scan the code here, or you will receive our email later on once all the recording is available. Holly.
I want to have a quick plug for our survey. This is a small thing, but I think it's going to be a great thing. It's very difficult when things come to the REB with a platform or a tool that we haven't heard of, that we need to review from scratch. So Beth, Sally, and I are putting out a survey. And yes, it is a popularity contest. Vote for the top 5 AI platforms, tools, whatever it is, that we will collect. And then we're going to submit it to the Privacy Office for privacy and security review. We need to make more tools pre-vetted available for you under certain circumstances, which is what those reviews do. So answer the survey. It'll take you 2 minutes tops, and it matters. If you want something reviewed and approved, you need to vote for it in that survey. Thanks.
Yeah, that should be coming out in the next month. So please watch out for that. We'll send it to everyone who comes to these meetings.
Yes.
And yeah.
Okay, I'm gonna stop share the screen now. So thank you, everyone. Hope you all have a great lunchtime.
Thanks,
Bye.
everyone.
Bye.
Thanks all.